Hello. Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS quality program consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health. Good morning, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I am Dr. Mingle, and I'm here to answer your questions to the best of my ability.
Excellent. Before we start, I want to invite our listeners to send in your questions. You can leave the questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. Okay, our first question today is from Roland. Roland asks, is it possible to do an annual wellness visit, an AWV, with telehealth platforms? Can they be done remotely?
Well, thanks, Roland, for the great question. The answer as often as the case is yes and no. We're still working under the COVID pandemic rules that permit remote AWVs. There's a bit of a challenge around the mandatory measurement of weight, BMI, basal metabolic index, and blood pressure. And most people are getting around that by either having the patient do measurements or bringing them in for a brief office visit just to get those measurements. But we expect the pandemic rules to end sometime in the next 18 months. It could drag on, but when the pandemic rules end, we have to go back to in-person AWVs. But I think in that that non-pandemic process where it's in person, it doesn't all have to be in person, and I think this process works extremely well as a combined remote in-person process. And the way I would do it is give the patient constant access to an HRA, health risk assessment, at home. Let them complete that in their own time. And I say constant because I'd like to see them have access to it all the time with an automated set of rules that flow out of that. If I have diabetes, I need to get periodic hemoglobin A1Cs and eye exams. And if I'm this age and sex, I need these preventative interventions done. These are the immunizations I should get, and when, and things like that. So the patient, as their health changes, can update that HRA, that health risk assessment, and get up-to-date recommendations through the system. But once a year, I think there needs to be a meeting of the minds, if you will, a face-to-face visit in which the provider reviews the output of the HRA and the recommendations with the patient, answers any questions that they have, learns from the patient the patient's priorities and goals, and has an opportunity to negotiate those, to say, well, yeah, I understand you want to do this first, but I think this is more important to your longevity and is foundational to get this done, that kind of thing. I think the patient-doctor relationship would benefit remarkably from this, and you can proceed through the year with a better handle, a better shared set of goals and priorities. The couple things that I think it makes sense to do it face-to-face, although I recognize that some people are just primed to take those recommendations, and I expect at least 20% of the time, if not more, patients are prepared to accept the recommendations based on those diagnoses. But when they're not, it's best to see them face to face. If they have some skepticism about one of the diagnoses or one of the recommendations that flow out of that. You may only notice face to face that there's the raising of the eyebrows or whatever it is that clues you in that they're not entirely on board. Um, and there's often some uncertainty about the diagnosis or the classification of the diagnosis. Um, Getting into these details makes some sense. There's often management choices. Do we start here or we start there? Do we go to physical therapy or surgery? Those kinds of things can benefit a lot from some face-to-face negotiation. So, I recommend everyone do annual wellness visits. I think it's a part of it's a strong part of a patient-centered approach moving forward. Um, uh, and even if you can't do it all remotely, I think it makes great sense to use some remote touch to get those done.
Great. Thank you, Dr. Mingle. We have another question today from Martha. She wants to know, do you have any advice for improving our chronic care management efforts?
Oh, great question, Martha. I've been a primary care physician for a long time, and I've started a lot of talks on this topic by saying, my name is Dr. Mingle, and I have care management envy. And what that means is, I've watched in my community a lot of care management programs come and go, for that matter. I once did an informal poll of all of the diabetes management programs that were in existence in our community, and it was just astounding. Some of the programs are owned by hospitals, some by community agencies, some by insurers, some by employers. When what I've seen, it's a fragmented, redundant system that typically floats single disease programs out there. And I just often think, boy, if you put this, thinking about the resources being put into all these programs, boy, what I could do with that in my primary care practice. I'd love to see all that money put into primary care, and I think on the same amount of same dollar, I could expand into a comprehensive disease or health management program. So I think what makes sense is first that primary care should own care management. I think the education for primary care doctors puts us in great position to do that. Our attitudes typically are conducive to that. Most people want to be doing that with their lives. So I think and part of the task will be as primary care doctors to rise to the task of doing it. As I said, the attitude is nurtured in training already. I think patients expect to have a degree of management from their doctors as they engage in a primary care relationship. And it can't, but what we lack is a tradition of systematization. Part of the training doesn't include methodology to do a comprehensive job at care management. Yet I think this is at the heart of patient-centered care and value-based care, for that matter. And I think it needs to be holistic. We can't. It does make sense to start and get our practice on the few high cost, high risk diseases out there, like diabetes, heart failure, stroke, breast and colon cancer. But ultimately, all patients, all diseases, all conditions, all preventative health should be managed in all patients. So again, I give you permission to implement a single disease management program, but as you do that, I'd suggest that you ask yourself, how will this process work for the 5 most common conditions? And how will it work for the 100 things I see only 2 or 3 times a year, but want to manage just as well as I do those common conditions? I see so many management systems jury-rigged to the point that they only work for that single condition, and that the practice really gets weighed down by the weight of adding a new system on top of that system. Really, our chronic management system should really scale to the entire set of needs of our patients. Now, specialties each own their own management of a set of events. And for specialties, it's not comprehensive or holistic care management for patients. It's typically an episode, some kind of event, or a specific disease. So if you're an endocrinologist, yes, you should be doing some longitudinal management of diabetes. Although I think in the well-run system, we'll probably be punting that management back to the primary care doctor when their systems are working well enough to be relied upon. But for the typical specialist, it may be around a specific condition and a procedure, let's say hip pain and an ultimate hip replacement. The management runs into the transitional care management, both transitioning from primary care into the consult or the referral, in preparation for surgery, the procedure, recovery, and then transition back to primary care management. So I think everyone has that bit of management that they need to own. Now, I'm heartened by the trends in this regard. The AMA has been creating, and CMS is allowing payment for a steady stream of new billable codes representing a broad spectrum of the care management continuum, and I'm pleased to see this. The bad news is it still introduces that level of complexity and frustration for patients and providers, making sure you've got the rules right for each of those care management codes. The fact that a phone call that the patient didn't ask for necessarily results in a charge sometimes tends to be a problem. And I really like the trend that's happening in parallel to that, proliferation of care management codes, the movement toward capitated care and care management. Because in those regards, we get paid to take the best care possible of patients, not by the visit or by the call, so we can roll those calls in to an excellent care program. So, I think in the near term future of primary care is to reimagine that primary care practice as a source of comprehensive or holistic care management. And I'd like to see you start thinking about your primary care practices as a healthcare help desk, and that will help you to imagine how to use your advanced systems to create a program that holds together for all patients for all conditions.
Great, thank you. So, Roland and Martha, thank you both for the great questions you sent in. If you have a question for Dr. Mingle, please leave it in a comment on LinkedIn or YouTube, or again at our email address, hello@minglehealth.com. Dr. Mingle, as always, thank you for sharing your insights with us today. That was really an interesting conversation. Thank you.
Well, thanks, Hadley, and thanks both to Martha and Roland. Don't hesitate to, as Hadley invited you, to supplement my answers, share your experiences, your additional questions. We can be smarter together.